So I've been asked to talk to you about sickle cell disease, and things have happened since the last year or two when I spoke about it the last time. I don't have any disclosures. I use different colors in some of the text slides because I really dislike showing slides full of text only, and at least this kind of emphasizes different parts of a text slide, but none of the colors have specific meanings in and of themselves. I came across this thing. You may already know about this. I was not aware of this, but this is a reasonably good summary of sickle cell anemia in 2021. And since you'll have these slides after I'm done, you might want to take a look at it. It's current and it's thorough and it's brief. So much of what I'm going to talk about is old, but much of what I'm going to talk about is new. So we'll start with a case. I'll talk about the history, definition, and the origins of sickle cell and something about its epidemiology. I'll spend a few minutes talking about pathophysiology because that's really important when it comes to understanding treatment. And I'll talk about the present and future of treatment for sickle cell disease. So the case is, and if many of you who have already been in sickle cell clinics, some of you have already met this woman. Ms. W is a 32-year-old woman with hemoglobin SS. In 2015, she had multi-organ failure and had a prolonged ICU admission. And since then, she's had a very debilitating peripheral neuropathy. Her baseline hemoglobin F is not terrible, it's 11%. She has frequent acute pain. She has chronic pain, excuse me. She gets frequent upper respiratory infections. She's had multiple episodes of acute chest syndrome. And frequently when she's sick, she becomes acutely more anemic than baseline, which is already pretty anemic, and she becomes symptomatic from her anemia. And so she's been frequently transfused with red cells. She has been on hydroxyurea for several trials of therapy and doesn't tolerate it very well, but doesn't seem to respond to it very much at all. She's followed by sickle cell clinic, pulmonary, neurology, and podiatry. Sickle cell disease has been recognized for at least 150 years and probably a lot longer than that. And there are different names for this disorder in many of the sub-Saharan African languages. The condition is described as early as 1670 by one family from Ghana. In the very early 1900s, a dental student from Grenada who was studying in Chicago had anemia and pain, and he was hospitalized, and his intern and his attending observed and published this description and named the cells sickle-shaped cells. And in 1949, Linus Pauling identified sickle cell disease as the first known disease caused by a single molecule and the disease of hemoglobin. So the definition of sickle cell disease is that it's an inherited mutation of the beta globin gene, which results in the polymerization of hemoglobin when the red cell is in a deoxygenated environment. It causes the red cells to assume a sickle shape. It results in hemolysis and anemia and vaso-occlusion, which in turn causes pain, organ damage, morbidity, and mortality. And this is a picture of the distribution of the endemic areas for sickle cell the sickle cell disease shown in the hatched black lines, and for malaria in the red. And you can see that there's a great deal of overlap. And just another word about that subject. One other thing, by studying the haplotypes of namely the polymorphisms, everybody with sickle cell has the same mutation. But the sickle cell mutation is closely linked to an area in the beta globin gene which has polymorphisms. And there are only 5 polymorphisms linked to the sickle cell mutation, meaning everybody in the world has 1 or 2 of this small group of 5 mutations, and these 5 polymorphisms are localizable geographically. And so the assumption was, or the interpretation was, that sickle cell arose in 5 different places simultaneously, or at least independently, in Western India and Eastern Arabia, in this region of Senegal, Benin, the Cameroon, and the Central African Republic, which was then called Bantu. There was a publication only a couple of years ago that seems to indicate that there is a single founder sickle mutation 259 generations ago, or 7,300 years ago, when the Sahara was wet, which makes sense since what we know about sickle cell tells us that the reason for the prevalence of sickle cell, the reason it has become established in populations, is the presence of the Anopheles mosquito carrying malaria. And this is a distribution of falciparum malaria. So this is something you just saw on the previous slide. And this is the distribution of red cell abnormalities across the hemisphere. So you can see that alpha and beta thalassemia are prevalent from west to east. And sickle cell is prevalent in sub-Saharan Africa. Hemoglobin C is prevalent in Western Africa. Hemoglobin D in South Asia, and hemoglobin E in Southeastern Asia. And you can probably plot G6PD deficiency in here as well. And these are all mutations which confer a survival advantage against malaria. In the United States, about 10% of African Americans carry the sickle cell mutation. In contrast, in Western Africa, about 20 to 40% of people carry the sickle cell mutation. In the United States, that results in a prevalence of about 1 in every 600 African Americans. And on the East Coast, it's present in about 1 in every 1,000 to 1,400 Latino Americans. And that's SS. And SC and S beta thal are present respectively in about 1 in 1,000 and 1 in 3,000 African Americans. This is so totally in the United States, there are about 100,000 individuals with the sickle cell disease, which is the name given to all the different genotypes, but not including sickle trait. To give you an idea of what this means, in Nigeria, there are about 150,000 babies born with sickle cell disease every year. And it's estimated that there are about 6 million people in sub-Saharan Africa with sickle cell disease. Sickle cell disease related child mortality still is high, although this is a couple of years old, and it's falling since that time. But many children don't reach their 5th birthday. So hemoglobin is composed of alpha globin and beta globin, and these are the two genes. Alpha globin gene is on chromosome 16, and there are 2 of them. Embryonically, there is an alpha-like globin called zeta. The beta globin gene is on chromosome 11, and there is a large and important controlling sequence called the beta locus control region, including a lot of sites that will determine thalassemia and beta globin switching. This is the epsilon gene. It's a beta-like globin, which is present early in embryonic life, and then soon gives way to gamma. Gammas, there are 2 of them, and they differ by 1 nucleotide, 1 amino acid, instead of a glycine. Here's a glycine, and here's an alanine at the same position. And then eventually there's switching controlled over here to the expression of beta globin. That all of those things become important. And this is just a little illustration of hemoglobin F and the 2 different gamma genes here in each heme section in the molecule. And this is hemoglobin A, which is the adult hemoglobin, which becomes present in all of our cells by the age of about 6 months after birth. Wow, sorry about that. There's a story behind that, but I will spare you. This is a close-up of the beta globin gene and the mutation that causes sickle cell disease. So in the 6th codon, an adenine becomes a thymine that results in the 6th amino acid, which should be a glutamic acid, becoming a valine. And this word valine becomes important, and we'll talk about it again in a few minutes. A picture of these 2 alleles is a picture of sickle trait, also called AS, where there's one normal beta globin gene and one normal sickle cell, one mutated sickle cell gene. A person who's homozygous has SS, and the second beta S mutation can be replaced by a hemoglobin C mutation or by a thalassemia mutation. A beta thal, not alpha, a beta thalassemia mutation will cause a sickle cell disease called sickle beta thalassemia, or SC disease. And I'll just remind you one last time that alpha thalassemia does not contribute to the genotype of sickle cell disease. So a person can have sickle trait and alpha thal. That doesn't give them a sickle cell disease. This is just to remind us what happens inside the red cell compartment during embryonic life, fetal life, and then after birth. This kind of yellow line here is embryonic hemoglobin zeta 2 epsilon 2. There's a little bit of alpha 2 epsilon 2, but you can see that this disappears by about 10 weeks of gestational age. And what becomes predominant is hemoglobin F, which is alpha 2 and gamma 2. There's a small amount of A, but less than 10 or 20% for most of pregnancy, most of gestation. And at birth, an infant will have mostly hemoglobin F, which is 80%, and a little bit of A, which is 20% here, which will explain why the actual phenotype of sickle cell disease doesn't appear until the hemoglobin F falls and the hemoglobin A rises. They cross at about, 2 months of age, where it's about 50-50. And by 6 months of age, they reach adult levels. So hemoglobin A is, 90-some%, and hemoglobin F is several percent. So I put this up here just to refresh our memory of the tetramer, because I'm going to show you another picture that may or may not resemble this, which is this. When I look at this, I see a rabbit, which is, I guess that's on me. But this is supposed to represent this change in shape of the tetramer between the shape it assumes in an oxygenated environment, where it's called relaxed or open and allows oxygen more easily to enter, and the deoxygenated environment, where it assumes a tightened position, which facilitates exit of oxygen from the hemoglobin molecule into the tissues. And this shape change is important. We'll get back to that in a minute or two also. This is just to kind of help visualize what I just described. So here, oxyhemoglobin in an oxygenated environment, the path in and out for the oxygen is open. And because it's in a high oxygen environment, the gradient favors entry of oxygen into the molecule. When it goes out into a deoxygenated environment, the gradient favors exit of oxygen out of the molecule. And as this occurs, the molecule tightens up to facilitate exit of oxygen. This is a picture of the oxygenated hemoglobin tetramer, let's say in the lungs or the arteries. And then as oxygen comes off in the periphery, this is a deoxygenated, shape-changed tetramer. And what's important here are these two things. Number one, this pocket is exposed, which is not exposed when the molecule is oxygenated. And number two, in sickle cell, there is a valine, which shouldn't be there. It should be a glutamic acid, but unfortunately it's a valine. And this valine is going to interact with this pocket on the neighboring tetramer. And this is what happens. Beta valine interacts with the neighboring beta hydrophobic pocket and back and forth, forming a strand. And 14 of these strands form a tetramer, form a polymer. And this is what happens inside the red cell, which should normally be a very smushy little, what do you call it? A very smushy little balloon with kind of jello in it. And instead it becomes like a bag of pencils, and that is not going to fit through small spaces. This is, you can ignore this, but this is a picture. This is an electronic photomicrograph of a polymer. And this is a photomicrograph of a cell with polymerized hemoglobin in it, a sickle cell. And this is a close-up of a cell which is being lysed because of those polymers. And you can imagine that having a blood volume full of these cells can only be bad. I put this on, this is almost kind of like not quite a non sequitur, but a brief sequitur, because there's increasing appreciation that there's a range of phenotype in sickle cell, and that may be amenable eventually to more specific and targeted therapies, where in some people hemolysis predominates. It results in and is caused by, in a kind of feedback loop, endothelial dysfunction. There's more hemolysis, hemoglobin is lower, plasma hemoglobin increases, more retics, higher, evidence of higher degree of hemolysis, and the phenotype is pulmonary hypertension, leg ulcers, priapism, and maybe stroke. Whereas some people have less hemolysis, higher hemoglobin, and they tend to favor, or their disease tends to favor avascular necrosis, acute chest syndrome, and more frequent pain. And just as a passing note, if a person co-inherits alpha thalassemia, that reduces the amount of available alpha chains to bind with the beta or beta S, and results in a decreased absolute concentration of hemoglobin S in the red cell, which paradoxically kind of, or ironically maybe, results in decreased hemolysis and an increase in circulating, blood hemoglobin. So the red cell count is higher in people who have alpha thalassemia along with their sickle cell. So the current therapy is, I'll discuss briefly, and it has to do with hydroxyurea, and then I'll discuss recent additions to the current therapy and a couple of recent glimpses into the future of treatment in sickle cell disease. So I put this, part of the reason I use slides that look something like this is to get away from all the text slides. But the other reason is that sometimes they are actually intrinsically useful. So here's a picture of the red cells in the oxygenated environment. This nice little picture shows that it's, blood flow is not bad. Oxygen comes off, they're in a deoxygenated environment. Here's the polymer of hemoglobin S, and no flow. But the key is not these blood vessel pictures. The key is what happens when hemoglobin F is produced inside of the red cells that contain hemoglobin S. And so hemoglobin S is shown as these little kind of orangey spheres, and hemoglobin F is shown by these yellow cubes. And by mechanical as well as electronic means, that the hemoglobin F molecules interfere with the polymerization of hemoglobin S. And so polymerization is slower, it is quantitatively less, sickling is slower and quantitatively less, and flow improves and hemolysis decreases. So hemoglobin F is a real target in what we want to accomplish, or what we are able, at least today, to accomplish for patients with sickle cell disease. It's been known that hydroxyurea raises hemoglobin F. Hydroxyurea was used originally as a chemotherapeutic drug for patients with myeloproliferative disorders or neoplasms. And people who study those patients and those diseases and that therapy recognize that hemoglobin F induced increases in that hydroxyurea induced increases in hemoglobin F. Along with a number of other therapies, but hydroxyurea was by far the easiest to administer and the most well tolerated. So in the early 1990s, there was a blinded randomized controlled trial of about 300 people getting either hydroxyurea or placebo. The trial was stopped early in 1995, where it was seen that the number of crises per year, the time to the first event, the time between the first and second event were all much improved on between 25 and 50% compared to placebo. There were also fewer episodes of acute chest syndrome, and there were fewer transfusions necessary. So hydroxyurea became standard of care. At the time, this trial studied patients with SS and S-beta thal with at least 3 episodes of pain per year requiring medical attention, and excluded patients who took more than an equivalent of 30 Percocet per month. So this applies to many patients of the kind that we see, but not to everyone. And without additional randomized controlled trials in adults, it has gradually been expanded to be applicable to, that we should apply this information to essentially all adults with sickle cell, unless there's a convincing reason not to use it. And the reason for that are the following 2 publications, which showed that there was decreased mortality in the patients who took hydroxyurea at 9 years and at 17 years. This is the most recent follow-up. I'm a little disappointed that that's the case. And there are some shorter follow-up studies by different populations which question whether, in fact, there is a survival benefit. But I think most people, because of the methodology here and the length of follow-up, accept that hydroxyurea prolongs survival in patients with sickle cell. It's also used in children, and it seems to be safe and effective in children as well. I just put this here because this is about chronologically where this occurs. 20 years after the beginning of hydroxyurea, the National Institute of Health published a very sort of comprehensive evidence-based management of sickle cell disease monograph. This has basically been abstracted and put in every review and kind of textbook and up to date. And it was sort of abstracted and abbreviated in a simultaneous issue of JAMA. So although now I'd say this is no longer new, it's something that you might want to be aware of if you have any interest in pursuing, your study of sickle cell disease. So in addition to hydroxyurea, what do we do for people with sickle cell disease? Well, the American Society of Hematology, which is our kind of organization of record, and which I personally think is a really admirable organization, has put together a kind of comprehensive multidisciplinary initiative in the study and treatment of sickle cell disease. And a couple of the things that they are pushing, that they are working on, are to form coalition with other disciplines to expand whatever available diagnostic and therapeutic advances there are throughout the world, and to obviously to expand research into sickle cell disease pathophysiology and therapy. So just a little sample of what they've done is, or what the American Society of Hematology has done. Here's a study that in sub-Saharan Africa, they tried to bring hydroxyurea in a major effort and in a major way to children in sub-Saharan Africa, and they were successful with 97% of the visits actually completed and 94% of the intended labs actually collected. And it showed a definite clinical response. It's also of note that very recently, a vaccine for malaria seems to be finally successfully developed, and that will be a huge thing in cooperation kind of medically and sociologically with the sickle cell effort. This is an example of another effort by the American Society of Hematology in which point of care rapid sickle cell testing became available. Until this, it was difficult or impossible for many affected people to actually get to healthcare, especially with newborn babies, to have the babies tested, to have them started on penicillin, to have them vaccinated. This way, at least the parents will know which of their children have or do not have sickle cell disease and be able to sort of act appropriately and accordingly. This is something you've probably seen in current therapy with or current management of patients with sickle cell disease. Those of you who've come to sickle cell clinic, and by the way, we really love having you in sickle cell clinic, me, the patients, the staff, and I think you really contribute a lot to the quality of their care in an important and positive way. So we try to do things kind of comprehensively, even though much of this is not strictly hematology. It all affects the health of somebody with sickle cell disease. And in particular, I think immunization is really important. We try to screen for retinopathy, for pulmonary hypertension, for nephropathy, and for iron overload. And these, we try to establish whether these patients take these medications and whether, if they don't take these medications, whether there's a good medical reason for them not to be on them. Excuse me. So I'm going to go over the most recent clinical trials and advances in the treatment of sickle cell disease. I thought I'd present the bad news first. These are 3 trials of interventions which showed no benefit. I'm not familiar with this drug, but cevuparin is a low molecular weight heparinoid. It's not anticoagulant, but it's anti-adhesive, and it didn't make a difference in the time to the resolution of vaso-occlusion. Pelaxamur is a polymer with a hydrophobic center and hydrophilic ends, which is synthetic and which reduces blood viscosity and red cell adhesion. And there was no difference in time in a randomized controlled trial to the last administration of parenteral opiates in a painful crisis compared to placebo. And IVIG, which was also used in order to reduce adhesion of red cells and white cells to endothelium, resulted in no difference in the duration of painful crisis in patients greater than 14. And there was a non-significant decrease in that duration in patients younger than 14. So this is a picture of the 4 current targets for therapy. This is a picture of a blood vessel. Here are the red cells. Here there's sickling. Here there is adhesion. By the way, I'll mention that based on ex vivo studies, there was a lot of strong evidence that the first observable pathological event in a vaso-occlusive event in most vascular beds in the body is adhesion of red cells and white cells, reticulocytes in particular, to endothelium. This occurs before sickling and before the actual vaso-occlusion occurs. And I guess by slowing flow past the area of adherent red cells and white cells, because of slow flow, this is usually in a post-capillary venule, the hemoglobin S has an opportunity to polymerize, the cell has an opportunity to sickle, and then vaso-occlusion occurs. So adhesion is one target. We know that sickle cells are vulnerable to oxidative stress, and polymerization can be stimulated by oxidation. That's a second target. We know that we can, as going kind of backwards in the physiology, we can see that by in some way causing a decrease of hemoglobin S polymerization would be a major benefit. And finally, if there's some way we can interact with the defective gene and either correct it or at least remedy it genetically, that would probably be the real kind of the holy grail and the sine qua non. So having these 4 areas in mind, I'm going to start telling you about 3 or 4 new therapies. One is the next 3 therapies have been developed and approved by the FDA over the last couple of years. Glutamine is an antioxidant. It's an amino acid. It's been used for decades. It's in a health food store product. Weightlifters and some athletes take it because they feel it enhances muscle growth. And in a randomized controlled trial, based on the premise that oxidant stress contributes to polymerization, 230 patients were randomized. The glutamine group had about a 25% reduction in pain, about a 33% reduction in hospitalizations, and adverse effects were not more common in the treatment group. And it's worth mentioning two things, one of which is on the slide and one of which is not on the slide. Two patients in the glutamine group died, but they had severe end organ disease. It was felt that their deaths were not due to treatment. About 10 to 15 years ago, glutamine was used in a randomized controlled trial in critically ill patients in the ICU. They were not sickle cell patients, and biologically, they had nothing in common with sickle cell patients. And it was thought that maybe the antioxidant effect of glutamine might improve their dismal prognoses. And in fact, there was greater mortality in the glutamine group. So in the sickle cell clinic, we tell our patients about this. We watch them very closely if they're on glutamine, but so far, there has been no adverse effects in our clinic. There have been no adverse effects in the published experience with glutamine in sickle cell disease. There is one adverse effect, but it's not medically serious, but it does cause abdominal discomfort. And so there's a reasonably high discontinuation rate with this drug. Crizanlizumab is an IV. It's given monthly after the first two doses, which are given after 2 weeks apart. And it reduces adhesion of white cells and endothelial cells by inhibiting P-selectin. 200 patients were randomized, and it reduced crises by almost half compared to placebo. The time to the first crisis was almost tripled. And the time to the second crisis was about doubled. So this was a pretty successful intervention. The rate of uncomplicated crises were about a third compared to placebo. So this is available at the main Mount Sinai and will become available at Mount Sinai Morningside. So we're referring patients for this therapy as well. And finally, the third recently approved drug is voxelotor, which this is a picture of the drug before it even was named. There are several molecules in here which bind to the valine. So you guys remember the valine I mentioned earlier, the valine that's not supposed to be there. And what this does is it prevents the change in shape of the hemoglobin molecule into the tense conformation. Remember, the tense conformation is the shape it takes out in the periphery after it gives up, or while it's giving up its oxygens, and it exposes that hydrophobic part, which is normal. But which is not normal, what's not normal is that valine, this is the sickle cell mutation right here, valine. And valine interacts with that when the pocket is exposed. So this prevents the exposure of that pocket. There is a downside. If the shape change doesn't occur, the release of oxygen from the tetramer is impaired. And so what the researchers had to take into account was, how can we inhibit that shape change partially to allow enough oxygen to come off, not to allow the tissues to get hypoxic, but yet to prevent enough exposure of the hydrophobic pocket to try to inhibit the polymerization step. So this is the result of the randomized trial of voxelotor. And here's the thing, and this is a pill. Voxelotor prevents the tetramer shape to change. It prevents the exposure of valine to its pocket and results in decreased hemolysis. Their outcome of interest was a rise in hemoglobin. There was not much mention of pain. It was not one of their pre-specified outcomes. They used 2 doses of voxelotor compared to placebo. There was a significant rise in hemoglobin, more than 1 gram or about 1 gram in the high dose group, 59% to 38% to 9% high dose, low dose placebo. and there was the average or the significant mean change in hemoglobin. The mean change was significant, 1.1 grams, 0.6 grams, and a fall in 0.1 gram. And this is just the illustration of that. The red is the placebo, the blue is the low dose, the green is the high dose. This is change from baseline of 1 gram, 1.5 grams, and minus 0.5 grams, meaning a fall in hemoglobin. I put this here because this is the annualized incidence of the vaso-occlusive crises in the two voxelotor groups and the placebo. And it is not, first of all, it's not significant. And second of all, it's not very dramatic. 2.8 episodes per year compared to 2.8 episodes per year compared to 3.2 episodes per year, which, raises the question of its actual value to the patient. Just by the way, in separate old trials, it has been long understood that the higher the hemoglobin in a patient with SS, the more frequent the pain is. Okay, so what about curing sickle cell disease? I mean, this is really the goal, either curing the genotype or at the very least curing the phenotype. And so 20 years ago, 25 years ago, it was understood that allogeneic transplantation for sickle cell would be curative. And there are two problems with this. One is that there was about a 10% mortality. Survival at 4 years was 91%. And there's about another 20% who don't die but aren't cured, meaning they lose their graft and they go back to their own endogenous hematopoiesis. But the other problem is only about 25% or so of patients with sickle cell disease have an allogeneic donor, whether related or unrelated. So, because this is certainly a cure for sickle cell disease. Well, one thought was maybe we can transplant from a haploidentical donor. Everybody has a parent or two parents, and well, everybody has two parents at some point, and each parent is a haploidentical potential donor. And there is some amount of success with this, but it's about 50%, maybe slightly less. Overall survival in this very small group was 100%. GVHD was high. Well, I mean, was not high, but graft rejection was close to 50%. It was 43%. And GVHD was 40%. So this is a work in progress, but it is not the answer. This is the first reported case of gene therapy. It was a viral vector mediated. It was in one patient. They also did two patients with thalassemia. What they did was they introduced a sequence into the beta globin gene that resulted in the expression of a hemoglobin F-like sequence, which interfered with the polymerization of the person's own hemoglobin S molecules in much of the same way as raising their hemoglobin F in a significant way would interfere with it. So taking that principle, using more recent technology, using a lentivirus with an inhibitory short piece of microRNA, and understanding that BCL11A is a gene which represses hemoglobin F expression. So if you remember the picture of the beta globin molecule and those 4 or 5 round circles on the left, which is the LCR, the locus control region, the BCL11A gene product stimulates the switch from gamma expression to beta expression. And by this lentiviral vector includes a interfering RNA, which is going to knock down this repressor. I'll show you this again in the next slide. And allow for the increased expression or the continued expression, or actually the recapitulated expression of hemoglobin F production. And 6 patients received this. Their hemoglobin Fs rose from an average of 1 to 8, a range of 1 to 8% to a range of 20 to 40%. And the patients who originally had, 3 of whom had stroke, 1 had recurrent acute chest syndrome, 2 had recurrent vaso-occlusion, 1 had recurrent priapism. None of those events occurred except for several events of decreased severity of priapism. So that was not done with CRISPR. I put this slide on for 2 reasons, both to show CRISPR, which is a technology for entering the DNA at a certain sequence and either adding or removing a base or several bases in order to introduce or remove a sequence. And in principle, this can take an abnormal beta globin gene and correct it to a normal beta globin gene. This is not yet reality, but this is the idea. In the meantime, what CRISPR is doing is entering the BCL11A gene and damaging it so that the BCL11A gene product is no longer functional. It will no longer suppress hemoglobin F expression, and a person with hemoglobin F expression will be able to sort of resist the consequent, will inhibit polymerization of hemoglobin S and avoid the consequences of sickle cell. So this is a picture of that. Here's the caspase-9. Here's the RNA that's used to guide its localization. This is the BCL11A gene. This is damaged. There is no more BCL11A, and so hemoglobin F becomes prevalent in the red blood cell. So this was done in 1 patient, a 33-year-old with 7 crises per year for the last 2 years. By the way, this and the last ones, these are transplants. Their stem cells are removed. Here. Their stem cells are removed. Where is this called? Then they receive full myeloablating conditioning, right? So their intrinsic marrow is destroyed, and their hematopoiesis is going to come from the cells the stem cells that have been harvested and manipulated. Same with this. Autologous stem cells will be harvested, manipulated, full myeloablative conditioning. So this is not a trivial therapy. And you can see that the hemoglobin rose to 12, the F rose to 40%, no pain, no transfusions. So our patient in February a year ago, almost 2 years ago, started on L-glutamine. I think she's intermittently adherent because it's not an easy treatment, and maybe she's feeling better. There's no objective correlative to this therapy. In September of last year, she started voxelotor. Again, maybe mild subjective response. There is an objective correlative to this, which is a rise in hemoglobin, which we haven't seen. And in January of this year, she started crizanlizumab. She only made the first few therapies, partially because she was in the hospital. She expresses a mild subjective improvement, and now she's becoming more regular on the schedule for her monthly infusion. So thanks for your attention. I guess we finished before 3 o'clock. I know we should have finished at 2:50, but that was never going to happen today.
Oh, this is amazing timing. Thank you so much for that, Dr. Cytryn. If anyone has any questions about this, you can unmute yourself or post it in the chat.
Hi, thank you so much for the presentation. I just had one question. Is there any drug that has been known to be superior to hydroxyurea so far?
No. Hydroxyurea works, I would say, it demonstrates subjective and or objective benefit in about 3/4 of the sickle cell patients who take it. Not everybody who could or is eligible to take it takes it. Among those who do respond, some, and I would venture to guess a half or 2/3 of those, really have excellent responses. I mean, go from frequent pain and multiple episodes of acute chest syndrome to year or 2 or 3 years without episodes requiring admission. So no, I don't think there is a better drug at the moment.
All right, thank you.
Hi, Dr. Cytryn.
Yeah,
Hi, thank you for the talk. I just had a question. I don't know if you mentioned this earlier, I may have missed it. Is there any, has there ever been like an initiative to initiate like genetic screening or genetic counseling for, couples who may have like sickle cell trait or are concerned about having offspring with sickle cell disease? Has that ever been a thing here in the United States?
it is. I don't think it's real common. I don't think it has a great deal of popular support, but it exists, and it's probably more common in sub-Saharan Africa. But there are two obvious issues with that. One is that many people who already have sickle cell disease, there was an interesting thing about, I think one of the patients who was successfully treated with gene therapy, who was interviewed on television, initially, or in the Times, initially felt that their disease was not, having had the disease themselves, this was not what they would consider a reason not to have a child or to terminate a pregnancy. But I think in the following, like a year later, I think she had come to feel that maybe she would try to avoid giving birth to a child with sickle cell disease because of all that it meant to her. I'm saying she, but I don't remember. It might have even been a male. But in any case, it would involve. I mean, if you can determine that the spouse was not affected, then the child would either be normal or sickle trait if the other spouse or the other parent was sickle trait, and if it was an affected SS person, the child would be sickle trait. But if both parents had at least one sickle gene, then there's a 25. If they're both sickle trait, there's a 25% chance that the baby will have sickle trait. And the question would be, how do you make that diagnosis early in the pregnancy? And that's not that easy. It's doable. And then you would have to kind of do it with the understanding that you would want to terminate the pregnancy if the baby was affected. And many parents don't subscribe to that view.
Thank you.
Yeah, I just have one question. That the patients who have the sickle cell gene make them more protected against like bad types or severe types of malaria? Does it show any protection against any other diseases, or?
I'm not aware that it shows protection against other diseases. I think it would be hard to demonstrate it one way or the other in cases of diseases involving intra-erythrocytic microorganisms. And I guess the ones that jump to mind would be Babesia. I'm trying to think of any other intra-erythrocytic microorganismal diseases.
I think the malaria, I read about something like that it can protect against malaria, or the incidence of malaria in sickle cell patients is less common.
So malaria is definite. I mean, I kind of tried to illustrate that in the early slides. The death survival from falciparum malaria is patients with sickle trait have better survival from falciparum malaria than patients whose hemoglobin is normal. Sickle cell SS, the affected, or S beta thal or SC, they may have a little more resistance to malaria in the sense that the red cells, their red blood cells, are not as hospitable for the parasite, but their biology is abnormal. It's pathologic, and they don't survive malaria well because of their other medical problems, which are results of sickle cell disease. So I don't think there's a survival advantage for malaria in the affected homozygotes, but in the heterozygotes, there's a definite survival advantage. I don't think there's a decrease in how frequently they're infected, but the severity of the infection and the mortality of the infection are both reduced in sickle trait.
Thank you.
Thank you so much again for that, Dr. Cytryn. It was a really great talk, and all the comments are saying the same. I think Abhinav just he just wants to have you back for more inpatient sickle cell management.
Sure, whatever you like.
But thank you so much.
It's always nice to talk to you guys. Thanks.